it gives me great pleasure to introduce Associate Professor of Medicine, Anita Rajasekhar, who is an expert in hematology and thrombosis and was responsible for developing the protocols for VTE prophylaxis for our COVID-19 patients. Anita, welcome.
Thank you, Dr. Southwick. So hello, and thank you for participating in this Coursera course. In order to learn more about this devastating COVID pandemic, we've learned a tremendous amount about this disease in the last year, and we still have a lot to learn. I think it's important for us to all keep in mind that much of this data is ever changing. And as yet, this topic, nothing is set in stone. And so we really need to keep up to date with the new data that comes out continuously on this topic. This disease has truly proved to be a global emergency, and I want to recognize patients that have succumbed to this disease and the healthcare workers on the front lines that are risking their lives each day to help care for patients. The topic that I will be addressing is thrombosis in COVID patients, and this is clearly an evidence-scarce zone. This presentation is an attempt to consolidate the global primary published data on venous thrombosis in COVID patients, to summarize current clinical practice guidance on the topic of VTE management in COVID patients, and to identify areas that require urgent attention for future research. So please also refer to Dr. Flamenhoff's previous talk in the Coursera course that eloquently outlined the proposed pathogenic mechanisms of hypercoagulability in COVID patients. There's really been a rapid explosion of knowledge with respect to thrombosis in COVID patients. The first publication in February 29, 2020 came out that described this possible increased risk. And since then, there's been over 1,000 more articles on this topic alone. The existing evidence is derived primarily from small retrospective analyses. We lack data from large prospective studies, and therefore it's really important to consider all of our observations and recommendations to this point as preliminary, hypothesis generating, and dependent on confirmation of further data. I'd like to start with a case scenario here. So here we have a 65-year-old man with a history of diabetes, obesity. He presents with fever and cough and shortness of breath. You'll see here on the vital signs, he is hypoxic, and labs reveal notably a mild thrombocytopenia, a decreased absolute lymphocyte count, a significantly increased D-dimer, and a prothrombin time that is mildly prolonged. The fibrinogen is also increased. So the question we need to ask ourselves is, are these coagulation abnormalities expected in COVID-19? So to answer that question, we need to go back to some original data that came out that first noticed in COVID patients this coagulopathy concern that we were seeing. And the most common presenting abnormalities in hemostatic assays are listed here. The most common pattern of coagulopathy observed is a significant elevation in D-dimer and fibrinogen, which correlate with a parallel rise in inflammatory markers such as CRP and IL-6. But what are the implications of this hematologic abnormality? It's apparent that some derangements are associated with poor prognosis. In one study out of China, you'll see the graph from that paper on the right side. You'll see here that those who had a higher D-dimer had a lower survival rate. And so there was an inverse correlation between mortality and D-dimer. Another meta-analysis of 9 studies with nearly 400 COVID patients found that platelet count was significantly lower in patients with a more severe COVID phenotype. And the worse thrombocytopenia they had, the increased mortality that was found. On the other hand, there are other labs that have a variable association with disease severity, such as prolonged PT and PTT or hypercoagulable TEG parameters. unlike classic sepsis-induced DIC, in COVID coagulopathy, there seems to be a minimal prolongation and in the PT and the PTT, only a mild thrombocytopenia, if at all, and labs supporting microangiopathic hemolytic anemia are rare. Importantly, we don't know whether these hemostasis lab abnormalities are due to the SARS virus itself or a consequence of inflammatory storm that accompanies this disease. Equally confusing is that many of the laboratory features of COVID-associated coagulopathy overlap with classic sepsis-associated DIC and microangiopathic hemolytic anemia. And differentiating these syndromes can be challenging. This chart here provides some guidance on discriminatory lab features. Certainly, some of these features are consistent with an ongoing acute phase response. And again, notable here is the significantly increased fibrinogen and D-dimer and the mild low platelet count, if at all, any thrombocytopenia. Collectively, these hemostatic changes indicate that there is some form of coagulopathy that may predispose to thrombotic events, although the cause is uncertain. Clinical outcomes that have now been well described are venous thromboses, such as pulmonary embolism or DVT, cardiac events, such as acute myocardial infarctions, and in rare cases, classic DIC, or disseminated intravascular coagulation. And the DIC seems to be more in the later stages of the disease. There are more and more reports of arterial events, such as acute limb ischemia leading to limb gangrene, and acute strokes, including those in younger patients. Here are some fundamental questions that we must ask ourselves in order to make sound clinical judgments surrounding thrombosis in COVID patients. The first, are ICU patients at a different level of VTE risk than other ICU patients? And it's likely that this is the case, but really we need comparative studies to confirm this supposition. Are patients at increased bleeding risk? And initial observations at this point suggest that bleeding is very rare despite the derangements in hemostatic abnormalities. Is standard VTE prophylaxis sufficient in all hospitalized patients? What about ICU patients? Does escalation of VTE prophylaxis impact clinically important outcomes? Do post-discharge VTE and bleeding rates justify extending anticoagulation prophylaxis after discharge? And do patients convalescing at home with mild disease require VTE prophylaxis? Demonstrated in this slide is the hierarchical triangle of VTE risk in COVID-19 patients. Clearly, the sicker a patient is, the more likely the risk of complications, such as thrombosis. And this concept is no different than any other acutely ill medical patient. Inflammatory response, increased age, and bedridden status, which are more frequently observed in severe coronavirus patients, may contribute to thrombosis and adverse outcomes. Traditional VTE risk factors may all predispose to thrombotic events, although it's not known whether this is additive or a multiplicative risk. Here, I've summarized key primary data of thrombosis from epidemiologic studies. And it's important to note here that all of these studies are retrospective studies with inherent biases. The studies mainly included ICU patients, although more recent studies have included general ward patients. It's noted that in the first study from China, no routine VTE prophylaxis was utilized, and this may explain the higher thrombotic rates that we're seeing here. Most other studies did use routine anticoagulation prophylaxis and even dose-escalated prophylaxis. And despite this, VTE events were not entirely mitigated. Some studies found that ICU patients were higher risk for VTE than general ward patients. And most studies reported outcomes with significant number of patients still hospitalized, which can of course affect incidence rates at the time of analysis. The follow-up duration was short in many of these studies, so we really do need long-term follow-up. And then radiographic screening strategies for VTE was varied among these studies. And of course, this can affect thrombosis rates. You'll see in the last column here that bleeding or DIC rates were quite low. The VTE incidence in studies varies for several reasons. Local diagnostic screening strategies can affect the rates of VTE incidence. Variable pharmacologic preventive strategies also can affect incidence rates. And both of these can usually overestimate the VTE risk. On the other hand, several other factors likely underestimate the VTE risk in the published studies. For example, we know that VTE risk is prolonged after ICU stay or hospital discharge. And however, most studies reported outcomes only until hospital discharge or during the ICU stay. So we really don't know if the risk of VTE is much higher if they were followed for longer periods of time. And mandatory isolation of COVID patients lends itself to higher thresholds for diagnostic testing to prevent transmission. So again, this could lead to lower diagnosis rates. Routine imaging may also be difficult to obtain or interpret in ICU patients that are intubated or prone positioned, again, potentially underestimating the VTE rate. And then competing causes of hypoxia may obscure the diagnosis of VTE. So regardless of how we analyze this, there's clearly a signal for COVID-19 being a prothrombotic disease. In our next talk, I'll focus on how to prevent and treat COVID-related thrombosis. Thank you.